Good morning, everyone. I am Kurt Langlotz, and I'm pleased to welcome you to today's Monday plenary session. We have an exciting program planned for you. Today's plenary session is dedicated to the memory of Dr. William J. Casarella, an RSNA gold medalist and former president of the American Board of Radiology and the American Röntgen Ray Society. Dr. Casarella is recognized as a pioneer in interventional radiology and credited with helping develop techniques used in cardiology, vascular surgery, and neurosurgery today. He graduated cum laude from Yale University, earned his medical degree at Harvard Medical School, and became a flight surgeon with the US Army. After military service, he completed a diagnostic radiology residency at Columbia Presbyterian Medical Center in New York, eventually becoming chief of the cardiovascular radiology section. He joined Emory University in 1981, where he served as chair of the radiology department for more than 2 decades. Dr. Casarella is a founding member and president of the Society of Interventional Radiology, and for his dedication to the specialty, Dr. Casarella received gold medals from the American College of Radiology, American Röntgen Ray Society, and the Society of Interventional Radiology. We're fortunate to have Dr. Casarella's wife, Dr. Kay Vittorini, here with us today. Kay, in recognition of his commitment and valuable contributions to the field of radiology, it's my pleasure to present you with this memento of our dedication of today's plenary session to the memory of Dr. William J. Casarella. Let's walk over here for a picture.
Thank you so much, Curtis, and thank you to the RSNA Board of Directors for this really wonderful honor for Bill. He loved the RSNA. He loved participating in committees, and he often would talk to me about being one of the co-hosts with Irv Khrushchev from New York of a long past audio journal called RSNA Today that I think was distributed to its subscribers quarterly on cassette tapes. Those are even more obsolete than the CDs that you were talking about yesterday, Curtis. He loved to come to the meeting. He loved to go to sessions to learn, to teach. He loved walking through the technical exhibits to see what new toys he could find for the department. But I think most of all, what he really liked was meeting and greeting his old friends. It always felt to us like we were coming here to a family reunion, and we loved Chicago and the meeting. As we get older, and since Bill has died, I think we all start to reflect on our lives, and how I have been struck by thinking about how really short our time on this planet is, and that if we want to make our communities and our practices and our world safer and better and more inclusive, we need to work with that, work towards those goals every day. Bill tried to live his life doing this, and our family really appreciates so much you remembering his life and legacy in this way. Thank you very much. It's good to see everybody.
Please welcome to the stage Dr. Marta Halbrun.
Good morning, and welcome to RSNA 2024. I'm Marta Halbrun, the Medical Director for Quality and Patient Safety and Imaging Services for Intermountain Health, a multi-state health system based in Salt Lake City, Utah. I also serve the RSNA in many capacities, and today represent the Radiology Informatics Council, the annual meeting Program Planning Committee, where I lead the informatics programming, and the Digital and Live Education Committee, where I'm the course director for the AI certificates. It is my honor and privilege to introduce today's plenary speaker, Eric Topol. A practicing cardiologist with Scripps Clinic and the founder and director of the Scripps Research Translational Institute, Dr. Eric Topol is a pioneer in cardiovascular medicine. Dr. Topol is the editor-in-chief of Medscape and authored 3 best-selling books on the future of medicine. He foresees changes in the practice of medicine, including promoting accurate diagnoses, giving clinicians more time for patient care, and partitioning patient risk for various medical conditions. However, with potential comes its own challenges, including how to forge a path forward to the future of healthcare. Please welcome Dr. Eric Topol to the stage.
Thanks very much. Oh, thanks, Dr. Heilbrunn, and thanks to Kurt Langlitz for inviting me and the RSNA. It's wonderful to be here, the largest medical meeting in the world. And I really hope to be able to take, as Kurt suggested, a wider angle lens to the AI transformation of the future of medicine, building on his presidential address from yesterday. So let's get right into it. This was Thanksgiving Day in the Washington Post. The Washington Post editorial board said, "Be thankful for AI in medicine." That was kind of interesting. And I'm going to suggest that that's a good front runner for where we're headed. We're not quite there yet, but we're, I think, inevitably going to be thankful for AI in medicine. And the reason we're going to be thankful isn't just because of the deep learning era of more than 10 years ago, which of course really set up unimodal AI, narrow task AI, supervised learning, but also, of course, the more recent development of transformer architecture that's set off for multimodal AI and so many foundation generalist models that we're seeing today that's really taking this into a high power multiplicative mode. And this transformer is something that I think is quite an extraordinary development. Even though it was rooted back in 2017, we didn't have the wake-up call until ChatGPT came along almost exactly 2 years ago. And because of not needing to look at each word or now the tokenization of the content, but rather to be able to look at it all because of multi-attention all at once, this has really transformed the AI future. And so, of course, we're not leaving deep learning and its reliance more on supervised, labeled, annotated images, but rather moving into transformers with the whole ability to rely on self-supervised or unsupervised learning. So that takes us to the Nobel Prize this year. What's interesting is Jeffrey Hinton did not get the prize for having predicted that radiologists would be vanish 5 years after 2016, actually, but he did get it for the work on deep learning with John Hopfield. And then what antedated the ChatGPT excitement of transformer model was AlphaFold 2 from Demis Hassabis and John Jumper. And they, along with David Baker on the protein design side, really leaped into this quickly because of transformer models and the work that they did on protein structure and design. So that sets off what I want to talk about today, which is the earlier era, the scan era, if you will, which is almost exclusively dedicated to scans, your world, of course. And I want to highlight a couple of aspects of that that are particularly exciting, that we're still getting our awareness about how effects they will have in the future. And then we'll get into the everything, in quotes, everything era, where we're all these newfound capabilities that we didn't have because of AI. So let's start off with the scan era. And I want to highlight with this more narrow task, unimodal, traditional, if you will, deep learning, that it's given us two things that we really didn't appreciate fully before. And the first of these machine eyes is going to help us with this problem of accuracy. So the buzzword for many years has been precision medicine, but when you keep making the same mistake over and over again, it's very precise. We need accuracy in medicine, and that's not what we necessarily have. And just to reinforce this problem with accuracy, the Johns Hopkins group published last year the fact that we have, from diagnostic errors, 800,000 Americans either having death or permanently disabled because of these errors. So that's a lot of Americans that are hurt by diagnostic errors that we need to do something about. And hopefully AI will help us get there. And as you know, way back, even 5 years ago, we were seeing the reports that there would be a chest x-ray with a unimodal AI trained in hundreds of thousands of chest x-rays that were annotated, supervised learning, and of course, they would be missed nodules like this one that turned out to be cancerous. So we already had a clue where this was headed, that this ability to detect things that might have been missed by radiologists. And the biggest randomized trial in AI still today is the mammography trial from Sweden of 80,000 women, half of whom had AI plus radiology interpretation, and the others had just the radiologists. And this is shown to be a higher pickup rate for breast cancer, as well as reduced time workflow. That study is continuing to see about long-term follow, whether it's changed the natural history of breast cancer, but certainly an improved detection of cancer. Now, what's interesting is that the gastroenterologists are really into this, and they are using more and more machine vision during endoscopy, and not only picking up more polyps, but also being able to detect whether or not they're likely to be cancerous. And indeed, there are now 44 randomized trials by the gastroenterologists for colonoscopy. And they've shown across the board highly consistent pickup detection of adenomatous polyps. And it has not increased the time of procedure. So we're seeing other specialties besides radiology get involved. And in addition, it's empowering patients. So this is an important thing that we don't acknowledge enough, which is that these AI tools are helping patients be able to self-diagnose abnormal heart rhythm, skin lesions and rashes, urinary tract infections from a kit that can be bought in the pharmacy, ear infections in children, and also, even in some grocery stores throughout the US, the ability to detect diabetic retinopathy, which in most, at least half of diabetics or more, never get screened for a reversible cause of blindness. It turns out that that detection of things that were the focus of the scan was just the beginning of where this is going. That the machine or digital eyes are so much more capable than we have given them credit. And what's interesting is these are all separate unimodal studies of AI showing that, for example, for the retinal image, that you could see the diabetes and blood pressure level of control, or that you could predict the person's going to have kidney disease, or the liver and gallbladder disease, or the heart calcium score from the vessels in the retina that's very well matched with the actual CT calcium score. Predicting Alzheimer's disease in people without any symptoms 5 to 7 years before they're actually diagnosed. Predicting heart attack and stroke, hyperlipidemia, and Parkinson's disease, again, 5 years. These are all separate studies showing things that we might not have actually expected that you could get from machine eyes of the retinal image. This goes on, of course, with retinal biologic age, the most recent publication. Let's look at the cardiograms features that are rich from digital eyes. I mean, I've been reading cardiograms for a few decades. I love reading them, but I would never be able to tell you the age and the sex of the patient, or the ejection fraction within a few percent, the difficult diagnoses that can be made, the hemoglobin to the decimal point from the cardiogram. Who would have guessed that would be possible? No less predicting a person with a normal cardiogram whether they're at likely risk of atrial fibrillation or stroke. Diabetes or pre-diabetes from the electrocardiogram, the filling pressure of the left ventricle, hyperthyroidism, predicting kidney disease, peripartum cardiomyopathy, and heart blood flow. It also extends to pathology. And again, these are separate unimodal studies of AI showing that you could, from a slide, know the driver genomic mutations that are responsible in many cases, whether it's malignant or benign, whether the site of origin can be identified, which is a problem in at least 5% of cancers, the structural genomic changes, copy number variants that might be in play, the response to therapy, and even the prognosis of the patient from a pathology slide alone with machine eyes. One was particularly surprising is the chest X-ray, which doesn't get enough respect. And what it turned out with this publication earlier this year is that it actually superseded the traditional atherosclerotic cardiovascular risk score that's been used for decades as the gold standard. And it was much more sensitive, the single chest X-ray, than what we've been using in cardiology all these years. And so what's bringing this whole machine eye story together is this opportunistic image interpretation. We are leaving so much rich information on the table when we get a readout of a scan. The capabilities are extraordinary, and this is just a list. The most recent one was published today from lung CT on coronary calcium, but you can see across the board, there's a lot of information that's being left behind that we eventually will get there. And I wrote about this in The Lancet, and I gave an example of a chest X-ray indicating that you may have type 2 diabetes. The coronary calcium score is your ejection fraction is normal, the 10-year cardiovascular risk, and then please review with your physician. This is where we can go if we set our direction straight to use the data that's in hand. Now let's move from that area of unimodal to multimodal AI. Again, relying on transformer architecture of these models. And I can't get into all the potential, but I want to get into a few areas that I think are especially noteworthy. And first, to a couple of definitions. These terms are used very loosely. A multimodal AI with large language models, generative AI, Gen AI, and the foundation models were the massive data with lack of the need for supervised learning that could be fine-tuned for specific purposes. And then generalists, it's really conflated with foundation models that are like ability to perform multiple tasks from that data set with inputs and outputs that are set up for pluripotential, if you will. And then diffusion models, which really relate much more to image-based models. But one other point, just before diving into this more, is there are two different multimodals that often can be conflated. There's the text, image, speech, or audio. That's multimodal. And there's also what we're talking about in the human data, all the different layers that make each of us unique. So we put together a review a couple of years ago about where multimodal AI can take us when you have all these different layers of data of a person, and you can then get into a much different level of precision medicine and accuracy medicine, things like hospital at home that I won't get into, which are certainly can be contemplated much more in the future. But I'll talk about a few of the possibilities that this lends itself to. So back over a year ago, the group led by Pierce Keene at Moorfield's Eye Institute published really, I think, the first foundation model in medicine called RetFound. We had the chance to be able to collaborate with him. This was using 1.6 million retinal images from the UK and predicting all those things that I showed you with the 9 different unimodal studies from the retina, all in one model. So this was the first beginning of ophthalmology using a foundation model for predicting many other diseases outside of the eye. And in fact, just this week, the group in the University of Hong Kong published another retinal foundation model and backed up a lot of these important findings. Now, radiology obviously is the leader, the pace setter for the movement from unimodal to multimodal. And here is a summary of where you all have been and where you're very quickly moving, and we're all learning from you from radiology. So back when the most narrow tasks, such as a lung nodule that I mentioned, or detection of a pneumothorax, and even some companies that were able to get that implemented. And then the second level was much more that link to care, like Viz.AI for diagnosis of a CT scan of stroke. But there is where the FDA is right now. There is no multimodal, as they call device or algorithm, that's been authorized to date. There's over 1,000 now of these that have been authorized. Mostly, the biggest chunk are in radiology. But we have not yet seen what are the criteria for moving into the multimodal AI in the actual use within the medical community. And that gets us to level 3, where Biomed GPT and Google more recently with their chest X-ray foundation model published for report generation. I'm going to show you a bit from level 4, the ability to have grounded reports. This has been seen with Microsoft Mera 2, as well as from MedVersa and A to Z. And then where we're headed eventually, which is this much broader generalist care that is going to be inevitable, that it be the foundation being from the Radiology AI Connect. So here's Biomed Parse. This was just published very recently, a couple weeks ago. This is from the Microsoft group, across 9 image types. So we're now moving out of radiology, traditional, and getting into things like endoscopy, pathology, dermatology. You are just setting this off because of what has been learned through the traditional radiology scans. Also Biomed GPT, similarly, not just radiology anymore. It's blossomed into all the other types of images and adding on things like the corpus of the medical literature. And this is MedVersa that I had the chance to collaborate with Pranav Rajperkar, who at Harvard, really the person responsible for building this model with 7 different modalities, like the others that I just mentioned, of images, including endoscopy and the retina, but also 11 different tasks with that. And so let me just show you a quick demo of its capabilities. This is just in MedVersa, the ability to put in the image, and this is the chest X-ray, getting its context, the prompt, the findings, but it isn't just, of course, radiology. Does the patient have pulmonary edema? Now we get into skin, and what is the diagnosis of this skin lesion, and segment that lesion. And then you have the ability to look at a CT scan and to query this visual querying answer capability. And so MedVersa, it was published as a preprint pending peer review publication. And then following that, Pranav went on to do A to Z. And this is, along with Mera 2 of Microsoft, the first grounded reports, and this is just showing you examples of that capability. Here, picking up 140 plus abnormalities in an abdominal CT scan, and then grounding reports here, first with pancreatitis, then fatty liver, and then, as you'll see, an aortic atherosclerotic involvement. So it just keeps building. It's really exciting to see. And again, we're learning from radiology for the rest of medicine. So it isn't just radiology, pathology is onto this in a big way. These are 4 exceptional models that have been published all in the last year. 3 of them by the Harvard group, but we're talking about an AI co-pilot for everything in human pathology, to all sorts of ways to have models that are extraordinarily accurate in diagnosis from a whole slide image. So that's what's going on in some of the foundation work. What about in the practice of medicine, where we're concerned about getting that accuracy amped up and efficiency, or productivity, if you will? And I put that in quotes, and I'll show you why it's in quotes in a moment. The first thing here is that we have to admit that the AI does a really good job of its text for completeness, correctness, and conciseness three C's, if you will. That is, if you look at the physician report versus the AI report, they are tighter, they're easier to understand, and they are more complete. So we can benefit from that type of summarization capability from the AI input, potentially. And I'll say potentially as in just a moment why I say that. These are two Google DeepMind models, the so-called MedGemini Foundation models. One's called MedPalm-2, and the other one's Amy. And the MedPalm-2 was a randomized trial of 20 internists looking at over 300 New England Journal CPCs. And what you'll note is that the top accuracy was with the AI only, not the lower one being the AI assisting a clinician. We'll come back to that in a moment. But both of these studies that are out there showed that there was a better accuracy of the differential diagnosis coming from the large language model, foundation model, than from the physician alone. But Amy was even more broad than that, because it didn't just look at diagnostic accuracy, the same graph I just showed you, but it also looked at 26 other outcomes. And for 24 of them, the large language model was better in performance. That included communication to the patient, empathy, patient management plan, all sorts of other markers of performance. And so when this paper was covered by Nature, its headlines was, Google AI has better bedside manner than human doctors and makes better diagnoses. So that was kind of interesting. Of course, we can qualify that in a moment, but I just want to point out that there have been now 10 different studies about empathy. Who would have ever thought that AI doesn't have empathy, but it can help channel it because of its language inputs to promote empathy, which is really interesting. And there hasn't been one study yet that's really challenged that. But what's really been a surprise, and you may have seen this, in fact, Kurt and I were talking about it just before we started here this morning. This paper that was appeared at the end of October in a JAMA journal is a randomized trial of 50 physicians. Half of them were training resident physicians, where they compared the differential diagnosis for 6 cases. And their conclusion was, and the New York Times covered it a couple of weeks ago, and if you tuned into television over the Thanksgiving holiday, I saw it on multiple CNN segments, that the ChatGPT accuracy was 90%, but the physicians with GPT was only 76%. That isn't the way it was supposed to work. It was supposed to be that the combined hybrid performance was going to be the best. Well, it turns out there are 5 of these studies. That wasn't the first one. I already showed you one that annotated that was much larger, that didn't get that attention, probably deserved to. And that was the one with the 300 cases and the 20 internists on this table, McDuff and colleagues. But what you can see is in these 5 reports, all of them show, 3 of them were radiologic and 2 were differential diagnosis, that the AI did better than the physician plus the AI. And we don't know why. There's 3 potential explanations to offer. One, of course, is that there's just automation neglect, a bias against automation by physicians. The second is that the physicians have never really gotten grounded with AI, the familiarity, how to use it best, things like prompt engineering. And the third is that these are contrived experiments that are not the real world. And so we wouldn't want to conclude yet that AI is better than the physician plus AI for these tasks, because these are not real world medical tasks. And that gets me to a very important point to leave you with this morning. If you look across all these studies, like passing the USMLE exam, or the front door to patients, summarizing charts, the one I mentioned, differential diagnosis we're talking about, which includes a bit of potential, if you want to call it clinical reasoning, promoting empathy, and then this final pathway to the generalist. All these studies essentially are contrived. They're not in the real world of medicine, and a paper that summarized over 500 reports showed that less than 5% of them use any real patient data. So it should be concluded these are preliminary findings that are not necessarily what we're going to see when we look at real world medicine, which is a very different than in silico medicine, or a lot of these experiments that involve, for example, actors as patients rather than real patients. But there is an area that is changing pretty quickly. And this is something that may not have been fully anticipated. And that's the area of ambient conversation during a office visit, a clinic visit. And these synthetic medical notes, there's about 50 or more companies working in this. The big gorilla, if you will, is the Microsoft Nuance DAX. But there's many, many startups in this space that are competing to be the leader of a change in how that note is synthetic from the conversation. And the only thing that has to be different during that visit is that the physical exam has to be articulated so it's captured in the note. Well, what's interesting is this generative AI, so it's not just natural language processing, it's using generative AI. That clinic conversation not only can be made into a transcript with audio links for the patient in multiple languages at the educational level of the patient, it is more accurate and structured than the normal notes that we see in Epic or Cerner or other IT tools. It can set up the appointments for follow-up, the scans, labs, procedures, the prescriptions, obtain pre-authorization from insurance company, nudge the patient about things that were discussed during the visit so they get followed up on, doing coding and billing, and even coaching physicians to become more empathetic and better communicators. And what was interesting is at Emory, a bridge which is used widely in that system, it's a company that I have served as an advisor. The head of IT, a physician, says, I get love letters that this has changed their practice, their marriage, their mental health. The average physician in health systems using the system has reduced 2 to 3 hours of data clerk work a day from this sort of tool. So this is something that we'll see a lot more of. And this is about the gift of time, giving it back to the patient-doctor relationship, getting more and more liberated from keyboards, less data clerk work, synthesizing the patient's data through going through all the records that saves a lot of time, the primary screening, the doctor list that I talked about, empowerment of patients, the streamlining of workflow, and the patient's ability eventually to head towards having a coach of their data. So now let's get into some of these things that are affecting not just the practice of medicine, but the future, which I mentioned the high resolution human being to give us even more high performance medicine. So back a decade ago, I wrote about this idea that we have all these layers of data that we're not able to integrate. In fact, back then we couldn't even collect the data. Now, for the most part, except for the immunome, we can get all the relevant data of a person. What's interesting is it's not just a one-off like the genome. This is longitudinal data. And when I wrote this and titled it Pre-Womb to Tomb, Bill Kelly, who was a prior chief of medicine of mine, he said, Eric, you really blew it. You should have called it From Lust to Dust. I think he's right. It would have been a better, catchier title. The point being is that longitudinal data and deep data is the way we get to high-resolution human beings. And so the group in Israel, at the Weizmann Institute, led by Aaron Siegel, has done the most extraordinary thing by having now over 15,000 participants with the most deep data acquisition ever made into a data set. They just published last month about the biologic clocks with all this data, and they do serial longitudinal assessment of everything you can imagine. So this is the way we get to high-resolution humans, and we're going to be doing a lot more of that in the times ahead. It's now attainable, and we have the analytics to be able to work with this data. So we can reboot cancer with AI. And we need to reboot cancer because screening is completely unintelligent based only on age. And we now know, for example, there are a lot more younger people that are developing cancer. And also we are For example, for women undergoing mammography, only 12% ever develop breast cancer in their lifetime. Why do they all have to have frequent mammograms? So we've written about this, that we should have layers of data to partition a person's risk rather than sending everyone and treating all human beings as the same. And this is a precision medicine approach. In fact, it could be also an accuracy medicine approach. And this now, as much has been written about this, but no one is doing anything about it yet. And so just as an example, pancreatic cancer is one of the most difficult ones to make before a person is already at stage 3 or 4. And in Denmark, the entire country of Denmark's data set, as well as the VA's data set, the largest US health system, they were able to predict a person's risk of pancreatic cancer from their electronic health record. And we're not doing that. And it captures many things that we miss because there's fluctuations in the lab values within the normal range, and non-specific complaints of the patient, all sorts of things that are in the record that we're not harvesting. And this is clearly a direction not just for pancreatic cancer, but across the board, other difficult to diagnose cancers that we're seeing the data come out, for example, ovarian cancer. Here's a study of over 116,000 women, just with the mammogram, that you could predict the risk of a woman getting breast cancer in the years ahead using AI interpretation of the mammogram. So that's just one layer of data. And then the Sloan Kettering just published a few weeks ago that they could do better than that with all different types of cancer. They had 5 different types of cancer that they looked at. They had the electronic record with unstructured text, imaging, genomics, tumor markers, stage, progression, treatment. And so in almost 25,000 patients with real world data, they could come up with a far better prediction of high risk. And that gets me to this topic that I'm really excited about, which is medical forecasting. And medical forecasting, we really could never do this. In fact, we couldn't even get the weather right forecast, right? But now with GraphCast, which was published, and another one coming out later this week, 99.7% accuracy. It has not been put out there yet, but it will be. And accuracy of weather forecasting will go to levels that are unimaginably accurate. And so why can't we do this for people if we can do it for weather? And that's where we're headed, I think. And so if you take all these layers of data, and the one that's really got excitement right now is plasma proteins. The fact that we can get plasma proteins, 5,000 to 11,000 of them, from just a couple of milliliters of blood. And so there are 2 companies in this space. One is Olink from Thermo Fisher. One is SomaLogic that has SomaScan. They get these thousands of proteins that we're starting to see a revolution in proteomics that's on top of the other layers of data, like the genomic sequence or the epigenetic clocks or the gut microbiome. And what's happening here is this quiet revolution is bringing new insights about human biology. So for example, the fact is that each of our organs ages at a different pace. And some people have 1 or more organs that are way out of line in terms of their aging, which would denote them at high risk. Other insights include the fact that we don't just linearly age, that there's certain peaks that occur between 35 and 40 odd, 60 and 80 when that's studied. So we're learning about the aging of people. We're learning about the causal proteins. This was just published last week in Cell. 660 different diseases. What are the proteins that are actually causal? These are new findings by having such a wealth of data about plasma proteins. So that gets me to what I think is the future. And of course, it relies on the foundation of medical scans, but it now extends it to all these other layers of data. When you have all these layers of data, and this includes all the things I've been mentioning this morning, then you get to a point of being able to pick up accurately who are the high-risk individuals. And it isn't just saying you're at risk. It's also with AI determining the temporal risk. If your risk is when you're 102, so what? But if your risk is when you're 50 or 60, that's what we need to know. And so these people are put under high surveillance by the timing of their risk, and then we can get into prevention strategies. This applies to coronary disease. It applies to prevention of cancer, for sure. And it applies to Alzheimer's and neurodegenerative diseases. So this is really exciting, and that's actually why I wrote a book called Super Agers that'll be out next spring. It's about that we don't have to necessarily, if we could, change the body-wide aging process, which is challenging, which introduces risk of cancer. But we can do a big thing by partitioning, defining the high-risk people, and putting them under surveillance and getting prevention, primary prevention achieved. And that's, in a sense, being able to get a huge impact on reducing the burden of age-related diseases. Last thing I want to mention is digital twins. Digital twins is an even further out in the future direction. So when we do clinical trials of an intervention, and we say there's a blockbuster, this is a game changer, and it's 10 per 100 people benefiting. What about the other 90 per 100 who get that therapy, but there's never been proof that they had any benefit? That's our best in clinical trials. Can't we do better than that? Or can't we have a complementary ability to differentiate who will benefit from an intervention? And this is, I think, the concept why digital twins of tailor-made matching can come into play. So the whole idea here is that if we had, again, hyper-massive data sets, and we could match up with nearest neighbor analysis all the layers of data of a person with their closest facsimiles, we then could be able to determine what are the best treatment and outcomes. That is a learning system, a real learning system from the species, if you will, if we ever could get to that point of a large number of people, multi-ancestry, rich, deeply phenotyped data. And so, for example, in cancer, we could be able to predict what would be the best therapy and outcomes based on a massive data set. And this is something that has been in play as a concept, but we haven't yet done this. I'm hoping someday we will, because this would be an excellent way to take our accuracy and learning from each other as to the best way to approach a patient for prevention or for prognosis or treatment. Now, before wrapping up, I do want to say I've given a very optimistic view here, of course, for the most part, mentioning, of course, that we have to be contained in our enthusiasm because we don't have a lot of real-world medicine studies. But there's a dark side of AI that you're familiar with, and it's not just confabulation or hallucination of large language models. There's more to it than that. Like, for example, just last week there was a paper that came out that maybe AI could worsen radiologist burnout. This was from China, a huge study of 6,700 plus radiologists across 1,000 plus hospitals throughout China, and AI use increased the odds of burnout and emotional exhaustion. And it was a dose response, which made it seem like it was more likely to be real. So we don't know yet, until we get this all out there, what are going to be the major obstacles. But I can just mention there are several. There's a medical community resistance to change. There's a fear of AI, too, that it's going to change the way patient-doctor relationship, which it might actually improve, but it can actually threaten with AI taking much more of a primary role. The reimbursement has not been established. There's only been a limited number of AI tools that have gotten reimbursed by insurers and by Medicare in this country. Regulatory, I mentioned, is a real problem. We've had over 1,000 algorithms get authorized. Many of those, if not most, are with very shaky data. Retrospective, in silico, never been published, not transparent, certainly not compelling. We need that transparency. We need compelling evidence, or the medical community is not going to change. And that is what engenders trust. And we have a problem, lack of trust as a default mode. And we actually have relatively little implementation of AI today for what it could be in the years ahead. So we need to really develop the work, the compelling evidence. We need to get the FDA, when they move to the multimodal era, which they haven't moved to tighten up the criteria of what would be considered an authorized algorithm for large language models, which we haven't yet seen even guidance about that yet. So this evolution of AI, which takes us to a dark side, which is kind of where the doomsayers are, and if you've read Yuval Harari's book, Nexus, that would be the last part of this cartoon, the kind of apocalyptic AI. I want to see if I can, hopefully, during this morning, get you to forget that last phase and think about what I would consider, and I wrote about in Nature just last week, is embracing AI. That is the opportunity here to help medicine, to help patients, to take us to new levels of accuracy, to a far better patient-doctor relationship, that gift of time theme, and to be able to understand the risk of a person by these various means, such as organ clocks, of what to be looking for long before a disease settles into a person. These are remarkable opportunities. This is why and hope that many of you are excited about where this can go, but we have to do the work to prove it, to validate it, and that's where we're short, and that's what certainly I'm calling for. So with that, I want to acknowledge the great people that I get a chance to work with at our center, at Scripps, the funding sources that we have to do that work. Thank you so much for having me at RSNA this year, and I hope as the years go forward, we'll see a lot more incorporation of good influence of AI in our medical practice. Thank you.
Well, please help me thank Dr. Topol for a fantastic talk, and thank you very much to everyone for joining us here for today's plenary session.